Welcome everyone. My name is Anita Pfeffer, and the title of my PhD thesis is Evaluation of Oncology Treatment Approaches and Clinician Practices for Safety, Efficacy, and Adherence. I have been working at the Pediatric Center Tűzoltó Street Department for 3 years, and now I'm a first-year PhD student. My vision is to improve the survival and life quality of oncological patients, and my mission is to identify the least harmful and most effective therapeutical opportunities for oncological patients. Here you can see my 2 ongoing projects. In my first project, I would like to investigate the effectiveness and safety of available therapies in adrenocortical carcinoma, and in my second project, I focus on the efficacy and safety of growth hormone therapy for pediatric brain tumor survivals. Let me introduce my first project with the title of Comparing the Effectiveness and Safety of Available Therapies in Adrenocortical Carcinoma. We are planning to do a systematic review and meta-analysis in this topic. Adrenocortical carcinoma is a rare malignancy with poor prognosis. Regarding the treatment protocol, a uniform guideline is not available, especially in childhood and in advanced stages. That's the reason why my aim is to investigate the effectiveness and safety of additional therapeutical modalities. 4 different stages of adrenocortical carcinoma can be distinguished according to the severity of the disease. As you can see, the gold standard therapy in all stages is surgery, but from stage 2, we can choose between different adjuvant therapeutical modalities. But there is a lack of knowledge whether each adjuvant therapeutical modality contributes to recurrence-free survival and overall survival. My clinical question is which adjuvant therapeutic modality provides the best survival and lowest number of side effects. I use the PICO framework in which population is patients with adrenocortical carcinoma, intervention additional adjuvant therapy, the comparison no additional adjuvant therapy, and the outcomes, mortality, and side effects. My hypothesis is that all types of additional adjuvant therapies lead to higher risk of developing side effects, but increased survival rate in adrenocortical carcinoma. I conducted a systematic search in the middle of November, and I found more than 17,000 hits. After the whole selection process, I had 81 eligible full text for analysis. Here you can see the most important outcomes of my project. We analyzed the effect of mitotan and radiotherapy on both recurrence-free and overall survival, and the effect of cytotoxic chemotherapy on overall survival. And now let me show you my most important results. On the first forest plot, we investigated the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without additional mitotan treatment. Hazard ratio is a measure used in survival analysis to quantify the relative risk of an event occurring in one group compared to another over time. It represents the ratio of the hazard rates between the 2 groups. We included 14 retrospective cohort studies in our analysis, and we divided them into 3 different subgroups based on the stage of the disease. We investigated separately the overall survival in patients with stage 1-4, in patients with stage 1-3, and in patients with recurrent disease. The importance of this subgroup analysis is that the effectiveness of the treatment can be highly influenced by the extent of the disease. The R-square number is 55, meaning the level of heterogeneity is moderate. The measure of effect is adjusted hazard ratio. If the hazard ratio is more than 1, so it is on the right side of the level of no effect, it means that the intervention group has higher risk for death compared to the control group. If the hazard ratio is less than 1, so it is on the left side of the level of no effect, it indicates that the intervention, so in that case, additional mitotan treatment, reduces the risk of mortality. The overall hazard ratio is 0.53, which means that additional mitotan treatment reduces the risk of death by 47%. This result is clinically relevant and statistically significant. We got similar results based on our subgroup analysis, and we found that additional mitotan treatment reduces the risk of death in patients with localized and advanced stages as well, and these results were clinically and statistically significant. On the second forest plot, we investigated the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without additional radiotherapy. We included 7 retrospective cohort studies in our analysis. The R-square number is 30%, meaning the level of heterogeneity is low. The measure of effect is adjusted hazard ratio. The overall hazard ratio is 0.72, which means that additional radiotherapy reduces the risk of death by 28%. This result is clinically relevant, but not statistically significant. We got similar results based on our subgroup analysis, and we found that additional radiotherapy significantly reduces the risk of death in patients with localized stages. On the third forest plot, we investigated the adjusted hazard ratio of overall survival of adrenocortical carcinoma patients treated with and without cytotoxic chemotherapy. We included 3 retrospective cohort studies in our analysis. The I-square number is 64%, meaning the level of heterogeneity is high. It can be caused by the heterogeneous population of the included studies. The measure of effect is adjusted hazard ratio, and the overall hazard ratio is 0.61, which shows that cytotoxic chemotherapy seems to reduce the risk of death. However, there is a wide confidence interval caused by the third outlier study, which must be taken into consideration when discussing these results. To sum up, we can say that cytotoxic chemotherapy seems to be promising, but more studies are needed to establish this evidence. The most important strengths of our analysis are the stage-based subgroup analysis, the high number of participants, and the complex and comprehensive analysis. To highlight limitations, most of the included studies are non-randomized studies. There is a high heterogeneity of patients' characteristics, and there are missing adjustments for important variables in some studies. In conclusion, we can say that mitotan treatment and radiotherapy prolong survival in both localized and advanced stages of adrenocortical carcinoma. Based on this, the clinical implication of our finding is that for patients with adrenocortical carcinoma in both localized and advanced stages, mitotan treatment and radiotherapy should be considered. Further research is necessary to improve the evaluation of the efficacy of cytotoxic chemotherapy and analyze the effect of the different treatment approaches in different stages and among pediatric patients. Here you can see the progress of my first project. I received all of my main results, and I finished the grid approach so I could start to work on my manuscript. I finished the methods part and about 80% of the results part. And now let me introduce my second project with the title of Efficacy and Safety of Growth Hormone Therapy for Pediatric Brain Tumor Survivals based on real-world data. We are planning to do an international survey in this topic. Brain tumors are the most common solid pediatric malignancies. Thanks to the improvement of the treatment opportunities, the 5-year overall survival rate is over 80% in these patients. However, as a result of oncological treatments, we often have to reckon with serious endocrine side effects. One of the most common is growth hormone deficiency, which can be caused by the hypothalamic pituitary dysfunction from the tumor itself, surgical resection, or radiotherapy as well. Now, there are well-developed international guidelines for initiation and use of growth hormone replacement. Despite this, several studies show that in clinical practice, the treatment of the affected patients, considering some important aspects, is not carried out in accordance with the current guidelines. That's the reason why my aim is to evaluate the management of growth hormone deficiency in the clinical practice and investigate the effect of the different therapeutical approaches for safety and efficacy. My clinical question is, how does the different management of growth hormone replacement influence the growth and the risk of recurrences and secondary malignancies in pediatric brain tumor survivals? I would like to use the PICO framework, in which population will be pediatric brain tumor survivals, intervention and comparison, the different management of growth hormone replacement, primary outcomes, recurrent disease and secondary malignancy, and the secondary outcomes, shortfall of height and catch-up growth. My hypothesis is that management of growth hormone replacement, according to the international guidelines, provides the best catch-up growth and lowest rate of recurrent tumors and secondary malignancies. The clinical implication is for patients improved quality of life, for clinicians optimizing growth hormone therapy, and for policymakers maximize the potential clinical improvement. As I mentioned earlier, my most important aim is to improve the survival and life quality of oncological patients by identifying the least harmful and most effective therapeutical opportunities for them. With these two researches, I would like to contribute to achieving this. My favorite quote is from Albert Szent-Györgyi, who said that research is to see what everybody else has seen and to think what nobody else has thought. Thank you for your attention.
Thank you very much. Congratulations. My question is related to your second project. So you just told that there are internationally accepted protocols that are available for growth hormone replacement, but still some clinicians doesn't apply that protocol, right? So it would make more sense to me to analyze why the clinician afraid of that treatment instead of the efficacy, because if there is an international protocol available, then it, for me at least, suggests that some studies are already available. Am I right?
Yes, thank you for your question. The majority of the literature data show that growth hormone replacement is not associated with higher incidence of tumor recurrences, but its use may increase the risk of secondary malignancies because of the mitogenic effect of growth hormone replacement. And I think so that maybe the clinicians has a fear to start growth hormone replacement as early as it should be started to avoid the risk of the tumor recurrence and secondary malignancies.
Thank you.
So wonderful presentation, thank you. My question is related to your first project. So what are the recommendations for the use of chemotherapy in adrenocortical carcinoma?
Thank you for your question. Based on the current guidelines, the routine use of cytotoxic chemotherapy is not suggested. However, for those patients, it can be considered who has very high risk of tumor recurrence or who have advanced stages. As I know, our meta-analysis will be the first one which aims to assess the effectiveness of cytotoxic chemotherapy. And as I mentioned earlier, I think so that more studies are needed to prove the effectiveness of this treatment.
Okay, thank you.
Congratulations to your presentation. My question would be related to your second project. You mentioned there are guidelines. What are the recommendations in the guidelines for the start of the growth hormone replacement?
Thank you for your question. Based on the current guidelines, growth hormone replacement should be started for patients with growth hormone deficiency 3 months after the surgical resection in a case of craniopharyngioma, which is a benign tumor, and 1 year after achieving a complete tumor remission in the case of malignant brain tumors such as medulloblastoma, ependymoma, etc.
Thank you.
Just have one question. So now, based on your results, now we have number of studies for radiotherapy and others for mitotanes and other for chemotherapy. Is there any study in the literature where directly compared radiotherapy to mitotanes, for example?
Thank you for your question. No, our first plan was to compare the effectiveness of the different treatments, but we haven't found similar articles. So we can compare just, or we can investigate just the effect of the different treatments separately.
So one brief question, if you have still time. In your second figure, there were 2 studies that show opposite effect to rest of them. Also, you mentioned significant or large heterogeneity. So do you know where there was this opposite effect? And sub-question, you mentioned that you have adjusted hazard ratio. Did they adjust for same variables, or and what were the usual variables they adjusted for?
Thank you for your question. In the outlier study, those patients received chemotherapy who had more serious disease. So those patients who has higher disease stage, who had hormone-secreting tumor, etc., so who had better or worse prognostic factors. So I think so that that's the reason. And we try to collect the different variables for which they adjusted, but not in every case. So, for example, all of the studies adjusted for sex, age, almost all of these studies for stage, but not everybody for other important factors. So it's one of the limitations of our